social and emotional development. If not caught in time, those challenges can develop into more serious learning and behavioural disorders in primary school and potentially into quite serious mental illness in adolescence and beyond. The government has decided in principle to expand the existing Healthy Kids Check to incorporate elements that assess a child's emotional and social well-being and development. We have also decided to shift the age of the check from 4 to 3, reflecting the advice of experts that the younger age presents the best opportunity for early identification. We'll be appointing an expert group to flesh out the details of those changes and to advise us on the level of existing service available in the community to support families with an identified need. Experts like former Australian of the Year, Professor Fiona Stanley, have emphasised that good early identification systems need clear referral pathways as well to support services which have sufficient capacity to meet demand. We recognise and accept the importance of that whole supply chain. To increase supports to families in this age group, we've decided to double the number of family mental health support services from 40 to 80. This well-regarded program delivers broad supports to families and vulnerable children, covering well-being, family relationships, school attendance and the like. We'll also vastly increase targeted funding to Medicare locals to provide counselling services through psychologists, social workers and occupational therapists to children and to their families. The models of treatment and support needed for youth aged 12 to 24 are a little clearer. This age is a critical point of intervention where a significant proportion of mental illness, including psychosis, begins to emerge. We know that left untreated, this has enormous potential to interrupt schooling, to prevent a smooth entry to the workforce, to damage relationships and to lead to substance abuse. I've met many Australians whose entry to adulthood followed this path and who've remained out of the workforce and socially excluded ever since. Patrick McGorry made the case very clearly last year for new transformative models of care for the young. Those models recognise that young people by and large don't use mainstream services, particularly mum and dad's GP. Headspace is a proven model designed to create a youth-friendly environment where young people feel comfortable accessing a range of services covering mental health, physical health and sexual health. The Howard government funded 30 services. Last year we committed to doubling that number, and this year we have decided to triple it to 90 services nationwide. The Headspace organisation says that this will deliver national coverage of the model, and we've also agreed to Headspace's claim for significant increases in core funding for each of those 90 services. The budget also includes funding to establish 16 EPIC centres, modelled on the Early Psychosis Prevention and Intervention Centre run by Professor McGorry in Western Melbourne. That EPIC has been running for almost 20 years now. It's an acute care service, as the name suggests, for young Australians with emerging psychosis. The first ever support for this model at a Commonwealth level was provided by the government in last year's budget. This year's budget vastly expands that commitment and will deliver broad coverage across the country. Now, being an acute service, we've said that we expect states to share the cost of the new EPICs equally. I'm pleased to say that in response to some representations arising out of last year's budget, that I've already received strong indications of interest from the states to partner with us in the rollout of this model. And we'll be talking further to them, obviously, about this element of the package in the near future. Australians with mental illness should be able to get access to basic primary care services when they need them and no matter where they live. For that reason, the budget also doubles the funding to ATAPS, access to allied psychology services. The ATAPS program funds divisions of general practice and will soon fund Medicare locals to provide counselling services to hard-to-reach groups in their area. The much larger Better Access program, by contrast, provides a fee-for-service rebate for those same services with no element of targeting. A recent evaluation of the Better Access program found that its distribution of services across the community was relatively poor. The further you live from a GPO, the fewer services you get. Out in rural Australia, and especially in remote Australia, service levels drop off quite dramatically. The data also showed a stark difference in access according to socio-economic status. In 2009, the latest year with full data, for example, the richest quintile, or 20% of Australians, accessed 2.5 times the number of services, attracting 3 times the Medicare dollars in rebates from better access compared to the poorest 20% in our community. The growth in ATAP's targeted funding will be directed at addressing those imbalances. Most of it will be targeted at lower SES communities, with some intended particularly for Indigenous communities. In keeping with our fiscal circumstances, this element of the package is funded through a redirection from the Better Access program by reducing the annual cap on Better Access consults from 12 to 10. We've also redirected funding from Better Access by recalibrating the GP rebates under the scheme. This will bring those rebates into line with standard time-based consult rebates, while still retaining a premium for those GPs of 27% on top of that standard fee. A glaring omission from Tony Abbott's mental health policy last year was any focus at all on adults with severe and particularly chronic mental illness. I'm particularly proud that providing more intensive and better integrated support services to this group is perhaps the central theme of our reform package. The budget this year provides dramatic increases to support programs like personal helpers and mentors, or FAMs. The Prime Minister, Minister Roxton, Kate Ellis and I visited a FAM service last week in Adelaide and saw firsthand the impact that this service has in bringing people out of often lengthy periods of isolation and exclusion, sometimes off the streets, restoring their confidence and their ability to make and enjoy everyday social interaction. Clients also develop their broader life skills, and $50 million of the $200 million plus going into expanding this program will focus on those clients who are ready to enter the workforce. But perhaps the most consistent message that I've received over the past 8 or 9 months that I've been the Minister from people living with mental illness and their families is that they want the services that they receive to be better integrated. This group and their families have to tell their story over and over again and get frustrated that the different service providers that they deal with often don't know what the others are doing. At best, this is frustrating. At worst, it results in gaps and in poor outcomes, and occasionally even profound tragedy. The 2006 COAG Agreement on Mental Health included as its flagship initiative a commitment to coordinate services for this group. With no money attached to those good intentions, though, that initiative went nowhere. In this budget, we provide funding for services to take responsibility for ensuring that all of the needs of the most severely unwell are being met. Organisations will be chosen through a tender process conducted in each Medicare local region. I expect the tender will attract some Medicare locals, but also many of the NGOs who have a strong history in this area. People will be able to be referred from a range of points, and if eligible, a worker will be assigned to take responsibility for coordinating all of that person's needs. They will arrange for service providers to sign on to a single care plan with the coordinator nominated as the key point of contact. Where an identified need cannot be met by a local service, funds will be available to purchase a service that meets that need. Now, while fairly simple at first blush, this is a revolutionary approach to providing supports to those with the most severe and chronic mental illness. It will provide great comfort to families knowing that there is a single point of contact to call on when a gap or a need emerges, and I'm sure it will result in greater levels of recovery and greater levels of social participation. Obviously, this group also receives support from state and state-funded services. Along with the discussions about the rollout of EPIC, we'll be seeking the agreement of the states to participate in this model, as well as their assistance in developing the assessment frameworks and such like. Given the significant money that the Commonwealth is committing to this proposal, I feel very confident of a positive response from them. The government will also take an additional $200 million to the COAG meeting that is scheduled to discuss mental health reform later this year. We want that money to help drive improvements in areas for which the states have responsibility. I've already particularly mentioned the capacity of major emergency departments to deal appropriately with the presentation, the admission and the discharge of people with severe mental illness. We also want to discuss ways in which states can expand support services around accommodation needs. This will be a very important meeting of COAG. My sense is that all state governments, no matter which political colour, take the challenge of mental health reform very seriously. And I'm confident that through this budget they'll also see that the Commonwealth will be approaching the meeting in a very constructive fashion. This package is genuinely reformist. We're not throwing money at old models. We're scaling up new, proven models, and we're driving innovation in some entirely new areas. As you know, though, mental health advocates have argued strongly for an institutional reform that would instil greater accountability and transparency into the system. The government has met those demands by creating the first National Mental Health Commission. This commission will be established as an executive agency within the Prime Minister's portfolio, reporting to her and to the Parliament. It's important that this commission be separate from the key line agencies, particularly health and families and communities, and that it focus on tackling outcomes rather than reporting on inputs. Instead of just asking how many beds there are in the system, asking how many people have got off the streets and into stable housing, how many are no longer regularly representing to emergency departments, and how many are reconnecting to the workforce, to their family and to society more broadly. The creation of the Commission and its placement under the Prime Minister is a clear indication, I think, that the government in no way considers that we've ticked the box on mental health reform and can move on to something else. As proud as I am of this package, we know that getting mental health services to the level that consumers need and the community expects will require long-term sustained commitment. I hope that the size of this package, but more importantly the shape of the package, demonstrate to the Australian community that Labor is in this for the long haul. Thank you for having me today.
Thank you very much, Mark. Let's move to questions now, and I'll get things rolling.